right, everybody. So guys, why don't we, I'm not going to start lecturing just yet because I know that people are going to be trickling in. But why don't we take right now as an opportunity to just, Dr. Desjardins told me that some of you had questions about some of the exam questions, the shock questions. So why don't we talk about that? So I know that the question in particular was the abdominal compartment syndrome question. So give it to me. Yeah.
So I had been confused with that one because the woman had postpartum hemorrhage. So I had in my notes that for postpartum hemorrhage you give blood products, albumin. And then in another slide it said that one of the side effects, one of the adverse effects of albumin is possible anaphylaxis.
Mm-hmm.
And that was one of the choices. So
right.
I had picked anaphylaxis because the question was something like, what would be an adverse effect to the treatment?
Right, right. So, so that question. So let me read it, and let's talk about it. So, let's see here. So the question says, the ICU nurse is caring for a patient in hypovolemic shock following a postpartum hemorrhage. For what serious complication of treatment should the nurse monitor the patient? And the options are anaphylaxis, decreased oxygen consumption, abdominal compartment syndrome, or decreased serum osmolarity. And the answer was abdominal compartment syndrome. Now, I don't have the breakout of the stats by answer choice, but by far the two most common choices picked were anaphylaxis and abdominal compartment syndrome. So the thing with anaphylaxis is any patient receiving anything is going to be monitored for an allergic reaction. Okay? So that's a complication that's not particularly specified by like the information in the question. Okay, it's actually something that you're going to watch for anyone who's getting any kind of treatment, right? And what you learned about postpartum hemorrhage, they're getting blood and blood products like albumin, particularly albumin. They're getting albumin because of the risk of abdominal compartment syndrome, right? So the abdominal compartment syndrome is when there is so much leaking of fluid out of the mesenteric and peritoneal capillaries. There's so much fluid leaking into that third space that it starts to get distended and it starts to press on the abdominal viscera and cut off circulation, right? So that's abdominal compartment syndrome. So the standard of care of giving albumin to those patients is actually because of that danger. And you know, I kept this question, like I didn't give points for both answers, even though I totally get what you're saying about the anaphylaxis, right? I didn't accept both answers for a couple of reasons. And this is where you're not going to like my answer, right? Because, and this is going to sound just a tiny bit shitty, but if I had taken both answers, you would not have remembered abdominal compartment syndrome as you move on, okay? It's actually kind of one of the difficult things about like these clinical classes, that the information and the questions can feel kind of random, right? Especially in relation to like what you learned in class. But these nursing questions get circulated around, and they come up in different textbooks, and they come up in the NCLEX, because they are really it's critical information, you know? So the idea that postpartum hemorrhage, abdominal compartment syndrome, like that's burned on your brain forever, right? So that's kind of part of why I didn't accept both answers. And that's not something that I tend to be a lot more lenient in patho because we're talking about the science behind it and not necessarily like the practice behind it. Do you know what I'm saying? Yeah. I know it sucks. Yeah. Yeah. No, it's the albumin is so the standard is anyone in postpartum hemorrhage gets albumin, right? And it's because someone in postpartum hemorrhage has lost albumin, and because there's this increased blood flow to the vessels around the uterus in that area, you actually run the risk of this leaking, this loss of plasma oncotic pressure and this leaking of fluid, right? So the albumin is to actually prevent.
So no was like
Yeah.
I got the
Yeah.
first explanation. Okay, so that is why.
Yeah. So tell me, I'm not sure I quite understand.
Because the way I read the question is, think of the treatment, which I knew was albumin.
Okay.
What is a possible reaction to albumin?
Okay.
That is how the question works.
So and sometimes we read questions and we insert things into it in our minds. So the question says, the ICU nurse is caring for a patient in hypovolemic shock following postpartum hemorrhage. For what serious complication of treatment? Oh, of treatment, that's what you're saying. Okay. Should the nurse monitor the patient? So she's being treated for hypovolemic shock. The albumin, it didn't say albumin in the question, so it's, I see what you're saying. It's the fluid replacement that they're talking about. Do you understand what I'm saying? So it's not specifically the albumin, but it's the fluid replacement. Yeah. Yeah, yeah. So central line. So that question was question 40. So the question is, the ICU nurse caring for a patient in shock is administering vasoactive medication as per orders. The nurse should know that vasoactive medications should be administered in what way? So the options are through a central venous line, by a gravity infusion IV set, by push for rapid onset of action, mixed with parenteral feedings to balance osmosis. And the answer was by push for rapid onset of action. So the idea is that the choices that you were balancing between is the central line versus the IV push. Not all vasoactive medications need to be administered through a central line. So between those two, the rapid push was kind of the better of the choice because they didn't mention which vasoactive medication was, yeah.
It's like, what does the nurse monitor?
Yeah, it's like, what does the nurse monitor when giving vasoactive? And you could choose why in that.
So what I have here, the question, maybe this isn't the question that you're referring to, but the question says the critical care nurse is preparing to initiate an infusion of vasoactive medication for a patient in shock. The nurse knows that vasoactive medications are given in all forms of shock. What is the primary goal of the treatment? No, that's not the one.
It was like they had 4 different options of things she was monitoring. One of them was like cardiac,
Okay.
IV site for infiltration.
Nurse is caring for a patient, excuse me, conditions deteriorating. She receives orders to initiate infusion of dopamine. What's the primary assessment and intervention specific to the administration of vasoactive medications? So the first option is frequent monitoring of vital signs, monitoring the central line, and providing accurate drug titration. The second is reviewing medications, performing a focused cardiovascular assessment, and providing patient education. Third is reviewing the laboratory findings, monitoring urine output, and assessing peripheral edema. And the last one is routine monitoring of vital signs, monitoring the peripheral IV site, providing early discharge instructions.
How do you decide where you're
It's drug specific, so dopamine goes in a central line. And this is actually why I cannot say this enough, right? So I went to nursing school from 2009 to 2011. I went into my first med-surg test, right? No, I think it was fundamentals. I went into my first fundamentals test studying for it the way I would study for my class. And I bombed, right? Because these questions, so I didn't personally write any of the questions that I chose for shock. But what I did is go through lots of test banks, and I picked questions that I thought were like not stupidly worded, you know, and tested really important concepts, because you gotta do the practice questions, you know. And what the switch that I made was to get as many resources as I could that had practice questions, and then just take them. And anytime I got something wrong, I'd look at the rationale, and I would just make a little note somewhere of like the piece of information that I was missing, right? So if I saw this in a practice test, I would read it, and it would say, like, you know, dopamine is only administered in a central line, and that's what makes it better than, and plus discharge, you're not worried about discharge, and you know what I mean? And I would write down dopamine only central line. And because I got that question wrong, it would stick in my brain. So, yeah, all I can tell you is that, like, nursing NCLEX questions, which is what this is supposed to model after, are not fair, and they're not cool, and they are often, sometimes they test you on very general principles, and sometimes they test you on, like, what feels like parenthetical minutia, you know?
like how from class though would we know what
Yeah.
all like vasoactive medications? Like how would we know
Yeah.
what do you? Because like I understand the question itself.
Yeah.
Makes sense. But I think the tricky part was
Yeah.
how
Yeah.
do you differentiate studying
Mhm.
to know that? I mean, like I've read the book.
Right. So for that particular question, okay, the other thing to remember is, for an answer choice to be true, every single part of the answer choice needs to be better than all the other ones, right? So if you narrowed it down to A and D, A was frequent monitoring of vital signs. You know that that's true, right? Let me just finish. Monitoring the central line, don't know, right? Providing accurate drug titration. For what they're describing, that's all definitely true, and you're not so sure about the central line. Then D says routine monitoring of vital signs, monitoring the peripheral IV site, providing early discharge instructions. You are not worried about discharge when you're giving vasoactive medications for somebody in shock. Do you understand what I'm saying?
Yeah, I think that the treatment stopped at that question that he was not very
Yeah.
Like that part made sense to me. At the central line. And
Yeah.
then we got to the next, that other question.
Yeah.
And that one was a IV push.
Yeah.
And so that's where it was confusing. I don't know how to differentiate the push, whereas like that other question was
Yep.
that you would use the central line.
Right.
So
Right.
that part, I think that question.
Because even if you didn't remember each medication, right? If you're giving vasoactive, if somebody's blood pressure is crashing and you're giving vasoactive medication, you're definitely going to do it by push, and you're going to do it fast because you want their blood pressure to come back up, right? To perfuse their organs. That's any time you're giving any kind of vasoactive medication. Some vasoactive medications, and it was in your chart, right, that I showed in the thing, some of them are administered by central line, and some of them you can administer by peripheral. So for one case, it's a global yes, and for another case, it's a sometimes, you know? And you guys are taking med-surg in 5 weeks, right? Like, what the frustration you're feeling is how physically impossible it is for you to wrap your head around all of that before you sit down and take the test, you know? But what's really important is that you've wrapped your head around it before you leave out of the 5-week med-surg thing. You know what I mean? So this is something that it's really hard because you guys wouldn't be here if you weren't like good students who try to do really well in every situation. But sometimes, all the time in this world, like, it's really learning the information that's more important than getting the question right. Do you know what I mean?
Yeah, I think I was just trying to
Yeah. It's drug dependent. Yeah, it's drug dependent. And that's one of those things that just knowing it's drug dependent is enough for clinical practice, because then you would, based on the drug, you would look it up and you would do it. But you got to know that it's, you know what I mean? Yeah. And I don't mean to be preachy. I'm just, yeah. Are there any other questions about that? Okay. And there's really a reason why, like, critical care is hard, right? And it's something that, like, people don't do as new grads. The only new grads that I've ever known who have gone into critical care have gone into these really sweet, like, training, extensive training internships, where, like, for 6 months you go to basically class from like 9 to 5 to specifically learn how to be a critical care nurse. You know, so it is a lot of content to try to. Shock is a really big and confusing topic. Okay. All right. So now that we have more of a actual class, so we are going to talk about 2 topics today. I'm standing in for Dr. Desjardins today to talk about asthma. This is actually her presentation, so I'm going to give my own spin on her presentation. And then we'll take a break, and we'll come back, and we're going to talk about the renal and urinary system. Okay. So asthma, we covered asthma in patho, right, last semester. And when we talked about asthma and we focused on the pathophysiology of asthma, we talked about it as being a chronic inflammatory disorder, right? So there's some kind of underlying chronic inflammation going on, and it's going on at the level of the bronchiolar airways. The basis for the inflammation is really falls under two basic categories. So there's, if you recall, there was that allergic type asthma, and then there was the non-allergic type asthma, right? And the allergic type asthma is by far much more common, and it's associated with what kind of age of onset? Anybody remember? Child. Yeah, so child, and then it's the non-allergic that's like in their 30s. It's like middle age. Okay? So the allergic type asthma is the sort of childhood onset, and the non-allergic type is the adult onset. And the non-allergic type, the actual clinical manifestations are very similar. It's just in the non-allergic type, they don't have any history of allergies, right? You do allergy testing, they're not positive for anything. And that non-allergic type, that onset of middle age, is actually associated with much more life-threatening asthma attacks. Okay? So it's a little bit more of a challenge to keep under control and to treat in an acute attack. So, and in the non-allergic type, the primary trigger for the inflammation and for the attacks are airway irritants, things like dust and smoke. Okay? In the allergic type, patients will often have an allergy or an allergen that they reliably react to. Right? Pet dander is a really common one. Okay? But they are also very reactive and sensitive to irritants, inhaled irritants as well. Okay? So you have this chronic underlying inflammation, and that chronic inflammation creates this situation where you have this persistent mobilization of monocytes and macrophages to the area, right? You have edema of the airway contributing to the narrowing. But what's particularly noticeable with asthma is that the chronic inflammation causes this dysregulation of the smooth muscle of the bronchiolar airways. So that muscle tends to be hyper-responsive and prone to spasm. Okay? So at baseline, right, when a patient's not in an attack, at baseline, the bronchiolar smooth muscle is somewhat constricted, much more constricted than someone who's not asthmatic. Okay? So there's a baseline narrowing of those airways. And then during an attack, there is actual spasm and really significant narrowing. Okay. So what kind of pulmonary disease is asthma? Obstructive, that's right, right? Like all the ones that are airway narrowing is obstructive. So with obstructive lung disorders like asthma, what do we see the most difficulty with? Inspiratory effort or expiratory effort? Expiratory effort, right? So what we see with asthma and other obstructive disorders is this tendency for air trapping, right? And a collapse of the airway when expiration is initiated. Okay. So the airway hyperresponsiveness, the mucosal edema from the inflammation, the mucus production from the inflammation. Okay, all of them are contributing to that narrowing. It's a significant problem in this country. It's especially a problem in urban areas, and it's especially a problem in urban areas among children who basically don't have as much money. Okay, so it's a really important problem in terms of health disparities, and the issue with the urban areas is that there's just poorer air quality, okay? And that poorer air quality increases the likelihood of the onset of asthma. Okay? Significant financial impact, $16 billion in direct costs and lost productivity per year, and the allergy-associated asthma is much more common. And then, you know, thinking about, as we talk about the drugs that are used to control asthma, when you think about that allergic type and that childhood onset, introducing these drugs very early becomes very problematic, and it's a really significant health and social issue. Okay. So we just reviewed the pathophysiology, the chronic inflammation, the edema, the increased mucus, and then the bronchoconstriction. Okay. And then, you know, remembering that this is an inflammatory disease, and there's this inflammatory process going on, and the release of all of these inflammatory mediators is important to keep in mind when you then think about the drugs that are used, okay? Because they're all going to target, especially the control drugs, they're all going to target this inflammatory process. Okay. Yeah. It's, I'm sure it's some kind of like copyright infringement, right? Because this is not like Bart, it's probably like Bert, but Bert Simpson. But, you know, so someone experiencing asthma symptoms, whether it's an acute attack or getting close to it, you know, there's a real anxiety and fear associated with difficulty breathing. Okay? People understandably become very, very anxious when they have a hard time breathing. So cough is very common, and it's usually a very dry, unproductive cough. Okay? And you'll see that kind of cough happen time you've got some airway reactivity. Okay? And the person will describe this feeling of like breathlessness if they can't cough. They don't really have a choice. They cough to breathe. Wheezing, so expiratory wheezing, but also sometimes inspiratory wheezing, depending on how narrow the airway is becoming. Dyspnea, and fearful. Their color may actually change depending on how deprived of ventilation they become or how compromised the airway becomes. Diaphoresis, they're sweating profusely from the anxiety and from the stress response. Their pulse will be high, so high heart rate. ABGs may reflect deoxygenation, and O2 sat may reflect desaturation. Okay? Again, it really depends. So remember that asthma as a narrowing pulmonary disorder interferes with the ventilation, right, which is going to lower that partial pressure of oxygen at the alveolar space. So you have a decrease in PO2. Okay. And what do you think carbon dioxide is going to look like? It's going to be higher, right, because of that airway trapping. So PO2 is going to be low, PCO2 is going to be high, right? So hypoxia or hypoxemia, hypercapnia. And if the PO2 is low, then hemoglobin saturation is going to be low, right? So they might have a lower O2 sat. So, nursing interventions. Obviously, most important, right? ABC, airway, breathing, circulation, right? That's always your first priority, no matter what, right? Relieving stress is important, but ABC, okay? They can be stressed out for a little while you are securing their airway. Improve airflow, okay? Which during an asthma attack is probably going to involve a beta agonist, okay? Some sort of beta agonist, like albuterol, okay? Something that mimics the effects of epinephrine. You want to dilate those airways to improve airflow. Okay? Now, you want to relieve symptoms, and then, of course, so the goals of sort of future control is relieving symptoms and decreasing future attacks. So with asthma treatment, there's two key parts of asthma treatment. There's the rescue treatment, right, or acute attack treatment, and then there's the control or long-term treatment. Okay? The long-term treatment is about reducing the inflammation. Okay? The rescue or attack treatment is really about bronchodilation. Okay? And then if you have good control, good inflammatory control, you prevent attacks. Okay? Now, during an asthma attack, you're going to administer oxygen. You're going to stay with the patient. You're going to obviously administer any inhaled drugs that are prescribed by the physician. Breathing exercises. So any kind of obstructive disorder, the breathing is usually a slow exhalation through pursed lips. Okay, has anybody ever seen that before? So this is true with COPD. It's true with asthma. If a patient, the airway narrowing and this tendency for the airway to collapse, if the patient purses their lips and breathes out slowly, it allows them to get out more air before those airways collapse. Okay? And so sometimes you'll see people being given like a little straw to breathe out because it forces them to purse their lips and it forces them to slow down. Okay? So breathing exercises, and actually they've found that those breathing exercises, if you have children who have asthma do this like a little bit every night, it actually improves their overall asthma control. Okay? So it's actually an area that is one of those, it's one of those behavioral interventions that like medicine doesn't do, that you can actually teach your patients and have a huge impact on their care, right? And then comfort. Obviously, this is a really anxious and stressed out patient, and especially, you know, thinking that about a child and a parent, and you know, so it can be really, really terrifying. Okay. Now, the inhalers. Does anybody? Well, I won't ask, but if you've ever seen. Have or have seen an adult use an inhaler, right, or train somebody on using an inhaler, it's kind of complex, right? So you wrap your mouth around the thing, and the timing of the trigger and the in-breath, right? It's a little complicated. With children, you won't be able to get them to do that, right? So what's often used are these spacers that the child can just press. It puts the medication in that space between the inhaler and their mouth, and then they can breathe in. Okay? But obviously, even the spacer can only be used by a child that can follow directions, right? A 1 or 2-year-old isn't going to cooperate with you. And in that case, often what's used is just a mask with a, what is that called? Nebulizer. Yeah, nebulizers are usually used for very young children who can't necessarily follow directions, okay? And if you can get that child to stop tearing the mask off, that works better, right? Putting them in front of like Dora the Explorer or something really, really helps. So the pharmacological management, as I mentioned, you have this rescue or acute quick relief medications, most commonly beta-adrenergic agonists, okay? And then anticholinergic drugs can also be used in conjunction with beta-adrenergic agonists. So the beta agonists, like I said, bronchodilation, right? They're mimicking the effects of epinephrine. Pharmacologically, there tends to be short-acting and long-acting beta agonists. Okay, the short-acting beta agonists tend to be used as the rescue inhalers. And the longer-acting beta agonists can sometimes be used as a part of the suite of medications for long-term control. And then the long-acting medications are trying to get the, generally speaking, they're trying to get the overall level of inflammation down. Okay, so they're going to be attacking this chronic inflammation from different angles. So steroid treatments are pretty ubiquitous for controller drugs. Okay? The corticosteroids, there's a variety of corticosteroid medications. Giving someone chronic steroid treatment is problematic in many ways, especially children. So cortisol's effect on the body includes things like pulling calcium out of bone, right? So for a child who's growing and building their skeleton, right, that's really problematic. So you will often see the steroid doses lower with children and the use of some other long-term acting drugs that aren't going to cause this bone demineralization. Okay? So we've got drugs called mast cell stabilizers, right? So those mast cells were the ones that can trigger inflammation. And why are the mast cells relevant for this allergic type, particularly for the allergic type asthma? They release histamine, and they are major players in that IgE-mediated type 1 hypersensitivity reaction, right, which is the classic allergy mechanism. So when someone is allergic to pet dander or pollen or something like that, the mechanism for the allergy is this allergen receptor that's sitting on the mast cell, right, that causes activation of the mast cell when it interacts with the allergen. Okay? And unfortunately, like all other immune reactions, the more experience you have with the allergen, usually the worse the allergy becomes. Okay? So if you can actually administer a medication that prevents the mast cell from degranulating, right, from activating, then you actually will reduce this chronic inflammation. Okay? And you're doing it without administering a steroid. And then, as I mentioned, the long-acting beta agonists to reduce the tone of that smooth muscle. And then leukotriene modifiers. The leukotrienes were inflammatory mediators that some of which are pro-inflammatory, and those are the ones that are the targets of this medication. Okay. Now, going back to this idea that children who live in urban areas where there is the most pollution. So I saw a talk a few years ago, and they talked about how in Manhattan, there's one part of Manhattan that has the highest rate of childhood asthma. Okay? And it happens to be about 125th Street, right? It happens to be in Harlem. And it happens to be very close to where all the buses park every day, right? So all the Manhattan buses, they park in one place. And that area, if you draw a 1 mile radius, you have the highest rate of childhood asthma. Okay? So it's very much a much higher risk for children who are in urban areas and in areas that are where they have the greatest health disparities. Okay? So you look at these drugs, good control, okay, is critical for asthma care. Because if you don't have good control, you have frequent attacks and frequent use of rescue inhalers. Okay? And what happens with frequent use of beta agonists? I didn't hear. What's that? Right, desensitization, right? So with frequent use of beta agonists, what you start to see is this tolerance. You start to see this reduced sensitivity to the drug, okay? Which means that the drugs don't work over time. And there's a rubric for if you're using your rescue inhaler more than so many times per week or per month, you are at high risk for developing this. Okay? Now, the worst case scenario is you're using your rescue inhalers so much that your airways have this, it creates this situation that without the drug there's actually a default constriction. You actually become dependent on the drug for a normal airway. Okay? So overuse of these rescue inhalers is extremely dangerous. Okay? Because when you're then in an asthma attack, they can't help you. All right? They can't recover your airway. So good control is extremely important. Now, these drugs that are under the long-term control medications, they tend to be more expensive, and they tend to require more management from a primary care clinician. Okay? So you have to be followed when a child is on a corticosteroid, okay? You have to have a primary care practitioner monitoring that drug with them. So patients with poorer access to health services tend to get poorer control and tend to it's a lot easier for them to go to the ER with an asthma attack and be sent home with an inhaler. You know? So they tend to rely more on the rescue drugs and really have poorer outcomes long term. Okay? And they're not taught the breathing exercises and all the things that a primary care clinician can actually bring to the table. Okay. Okay. So just some more detail on the longer acting longer-acting drugs, right? Very important when you are either taking or administering corticosteroids. Oral care is extremely important. Okay, so after every use of because they're often in steroids, and that's actually well, I'll get back to that in a second. But so they're inhaled steroids. So you get this film of steroids on the mouth. And steroids, they're anti-inflammatory, correct? Which means that all the little bacteria in your mouth, right, they have a field day. And it can actually increase the likelihood of dental caries, cavities. It can wear away the oral mucosa. Okay? It can really be damaging to the mouth. Okay? So cleansing the mouth, rinsing the mouth after every single use, and teaching the patient to do that is extremely important. Okay? So with corticosteroids, inhaled use is preferred because, especially with children, you're going to have far less absorption into systemic circulation if you have an inhaled corticosteroid versus an oral corticosteroid. Okay? If it's inhaled, it's really made topical application. Okay? And so you don't see the side effects as much, the systemic side effects like the weakening of the bones and things like that. Okay? Okay. Okay. So a variety of drugs used, again, long-acting, the beta agonists. Okay. The long-acting beta agonists are not for acute attacks. Okay. They're not going to be helpful for acute attacks. Okay. So the treatment, the pharmacological treatment of asthma, yes, ma'am. That's a good question. So the longer-acting beta agonists are not that they don't contribute to desensitization. It's just that the doses given versus the sort of pharmacokinetics, the how long they stay in your body, are such that it's far less likely. Does that make sense? Yeah. It's not any beta agonist chronically taken increases the likelihood of desensitization. But when you do an inhaler, like an albuterol inhaler, you're just flooding your lungs with basically epinephrine. The longer-acting ones, they're agonists, but they tend to have a little closer to like a partial agonist kind of thing. So they just reduce the likelihood of that. Okay. So, like most chronic conditions, the pharmacological treatment is a sort of a stepwise treatment regime where the fewer the meds possible is preferred. So with less severe forms of asthma, the use of a rescue inhaler only when necessary is preferred. And then as the asthma becomes worse or more persistent, the incorporation of longer-term drugs and less reliance on inhalers is preferred. Yeah. It isn't always true that every patient with intermittent asthma, that it's going to progress to this persistent asthma, especially with children. So the whole world of allergies is a really mysterious world, and one of the interesting things is that children sometimes outgrow allergies. So a child can have a sensitivity to something and have 3 times a year they've had or 3 times in the last year they had airway narrowing. So in that time they have no history of asthma. How are you going to treat them? You're going to treat them with an inhaler. And if you then have no evidence of asthma, there's no need to introduce these drugs that have side effects. You know what I'm saying? So it has to become, attacks have to become more regular for you to then introduce the need for these longer-term drugs. Yeah. Not every child is lucky enough to outgrow allergies, but some do. Yeah. And it's interesting, they won't even allergy test children usually before they're about 2 years old for that reason, that when they're younger than that, they often won't, the allergy won't persist. Yeah. For someone with persistent asthma, and this is another thing that requires a lot of patient teaching, where nurses and nurse practitioners are much, much better at this than other clinicians, or at least certainly better than general clinicians at it. One of the most important things for good management of persistent asthma is regular monitoring with peak flow measurements, right? Peak expiratory flow measurements, which means that the patient has to do this little breathing test frequently to assess the status of their asthma, even when they don't perceive that there's a problem. Okay? So the peak expiratory flow, there's a little device, and I've got a picture of it here. Yeah. So there's this little device that has this element inside of it. So the air flows through it, and there's this element inside of it that moves through the tube and can measure basically the airflow. So what the person does is they, with the measuring device at 0, they blow into this thing as hard as they can, as fast as they can, right? So it's a forced expiratory effort. And the little slider will measure the peak of airflow. Okay? Now, as someone's asthma underlying constriction becomes worse, their peak flow will decrease. And that is true even when they don't sense that there's any symptoms. Absolutely. So as their level of constriction increases, their peak flow will decrease. And that decrease will happen even when they don't really feel the constriction. They don't feel any symptoms. Okay? So on a really good day, they get this peak flow that's their baseline, that's their 100%. Now, they do this every day, and what they might notice is there's a slow decline in peak flow over the course of the last week. Okay? But they don't feel breathless, they don't feel any problems. That decrease in peak flow over that week reflects an increase in inflammation and an increased risk of attack. So if they can do frequent peak flow measurements, they can better titrate their controller drugs. Okay. Good asthma care is about preventing attacks. Okay. Not just rescuing somebody from the attack. Make sense? So what we need is a legion of nurse practitioners to go into Harlem, right, and just teach all these things to all these kids so they can grow big and strong and beat it. All right. Yeah. So in addition to the peak flow monitoring, teaching patients how to do this, and you can imagine it's quite a bit of teaching, right, to teach both the parent and the child this peak flow measurement and the breathing exercises, but also to teach patients and their families to keep a log of what was happening before their peak flow measurements went down, before attacks, so they can really identify what are your triggers, right? And try very hard to avoid those triggers. Okay? Because greater exposure creates greater reactivity for the future. All right? And then also having a clear action plan of how they're going to seek medical attention if they notice the peak flow measurements going down. Okay? If they notice signs of an attack coming up. If they notice they're using their rescue inhaler more often. Okay? Questions about any of that? So in any of these sections of the course, I welcome and encourage you to revisit parts of patho that are relevant to it if you feel that that is helpful to you. For the sections that I teach, there might be specific topics that I will actually ask you to go back and review that. But you know, going back and reviewing the asthma section from last semester might be helpful. But I'm not saying that there's specific information on the test that's, you know, from last semester, but it might be helpful. Okay. Okay. So. Does anybody do what I was mentioning about doing practice questions, using that to study? So where do you find your practice questions? What's the name of the book? So there's a series of books called Success. So like, yeah, Med-Surg Success, OB Success, Pediatric Success. I lived by those books when I was in nursing school. And they have really good rationales. They're really hard questions. They're so much harder than any question you're going to come across, either on the NCLEX or in a class. But those are really, really good books. NCLEX review stuff, there's actually apps that you can download. I used to this is TMI, but I used to go to the bathroom and take questions, you know, on my phone with my app. But it's just, it's amazing how, and I'm telling you, that's how you study for the NCLEX too. You just answer a million questions. Yes, ma'am.
The review cards that were recommended for this course,
Mm-hmm.
I found very, very helpful.
Review cards, okay. And they're like something you purchased?
Yeah, it's through Living Cloud, I think. Rationale's really good.
Awesome. That's great. And you know, share that with your, like, classmates that are, like, going to take med surg in the next section, you know? Like, I can't emphasize it enough. It was something that was a revolution to my teaching, not my teaching, my learning as a nursing student, and something that was completely different to anything that I had ever done before. Okay, there's not to scare you or anything at all, but there's a saying that I've heard a couple people, including myself, I agree with, about the NCLEX, and it's like, the more confident you are, the worse that you are doing, right? And the more that you walk out of the NCLEX feeling like you failed, you probably passed. That's much more likely that you passed. And the reason is, did anybody tell you guys about how the NCLEX is put together, about the algorithm that they put together? So it's like passing questions versus non-passing. So usually when someone is answering questions and they feel good, it's because it's knowledge and they know the knowledge, right? So they ask a question about a piece of information and you know that information and you get that question, you answer that question. Those knowledge level questions that you either know or don't know, and you feel good if you know, they are not at passing level for the NCLEX, okay? You have to answer a certain number of those to get to the passing level questions. And the passing level questions are judgment calls, prioritizations, okay? And so those things are, you will look at that question and it'll be like, there's more than one possible answer here, right? But what's more right? And so what you do is you'll be taking these questions, you'll get a certain number of these knowledge questions under your belt, and then you'll get into the passing level question world, right? And that world is a scary, nebulous world, but what you'll do in that area is you'll go back and forth, right? You'll answer one right, you answer one wrong, you answer one right, answer one wrong. But as long as you answer more correct ones than incorrect ones, you'll stay in that passing. And once they get to a certain number of right passing level questions, the thing shuts off and you've passed, okay? Minimum of 75 questions, maximum of like 260 or something questions. So my purpose in telling you this is don't worry about getting questions wrong, right? Don't worry about that. Try to get a little more comfortable with that feeling of like, nah, I don't really know, you know? And you know, you got to know the knowledge, but also, you know, practice those questions so you can get a sense for themes for the priority and judgment call stuff, right? One theme that I noticed when I took studied for the NCLEX is potassium, always a medical emergency, okay? If there's a potassium high or low in the answer choice, that's the priority. ABC, airway, breathing, circulation, always the highest priority, okay? So it's stuff like that that you really only catch on to when you take these questions over and over again, okay? All right, so let's take a break. Let's see, it's 10. So why don't we come back at like 10:25, okay? how's it going? How'd his the morning go? Oh, okay, okay. Okay, so how did it go at the doctor? I can't hear you. You're what? Okay. 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 Good. Thank you so much for taking this. Yeah, I'm fine. I was just checking in. Oh. You're talking to me now? Good, good, good. I'm just in a break here at work. Giving the students a little bit of a break. How are you doing? You're aggravated by? Which part? Yeah. Yeah, I understand. Yeah, it's okay. I mean, I understand. That's okay. Well, I was just thinking about the flow. Yeah, I mean, I think you understand what my thinking was. Um, well, I'm glad that I know now. You know, I'm glad I know that now. I understand. I understand. Listen, I've been living and breathing this for 2 weeks. I understand. When you cry. so I get it. Yeah. Yeah, I did, but she was still crying because that's why I knew she needed to go back to the doctor because she just cried all day yesterday. Yeah. Uh-huh. Mhm. Mhm. Right, right, right. Okay. Right. Mhm. Right. Right. That's good, yeah. Right. Right, right. Mhm. Mhm. right, everybody. Why don't we continue? Okay. So we're going to move on to the renal and urological system. I showed this picture to my husband this morning, and he's like, what? What is it? And he's like, oh, it's a kidney with a bow. I'm like, read it. I'm like, hello, kidney. I'm like, you are so literal. It's ridiculous. So anyway, I thought that was cute. I like the kidney, as you guys know. I know. All right. So we are going to talk about the renal and urological system from the perspective of we're going to sort of review some of the basic parts, anatomy, physiology. I'm going to go pretty quickly through that. I know that, so the renal system is one of those systems that often, every time it comes back up, like quite a bit of review is probably a good idea, just because it's sometimes it's hard to get your head around. But I'm going to review a little bit, but I welcome you to revisit some of the renal physiology and pathophysiology we did last semester. But to review some of the basic essential functions of the renal system, which helps us understand what we see in patients when renal function declines or when there's some sort of disorder affecting renal function. Essential functions: filtering the metabolic waste, especially nitrogenous waste, okay, from the blood, plasma, and excreting it from the body. So the kidneys have, essentially their day job is a filtering organ. Okay? That is kind of their primary function. And the percentage of cardiac output they receive is very reflective of this job that they have to filter the blood. So they receive on average about 20% of cardiac output, and that is compared to them being less than 1% of the body mass, right? So for a very tiny organ, they receive a significant amount of cardiac output. And so basically the kidneys are going to, your entire blood volume is going to pass through the kidneys every few minutes. Okay? So it's a really significant level of perfusion. The kidneys also participate in the maintenance of a constant extracellular environment, which is required for proper cell functioning. Okay? So the kidneys play an incredibly important role in keeping ECF healthy for cell function. So anything from maintaining normal volume, maintaining normal osmolarity, right, tonicity, maintaining normal pH, okay? All of those things, electrolyte balance, all of those things, the kidneys play an incredibly important part in it. Okay? So that's very essential. The kidneys are also the primary route of elimination for most drugs that we take, most drug metabolites, most byproducts of endogenous metabolism, okay, and endogenous chemical messengers. Okay? So hormones, other chemical messengers in the body, they get either excreted in the same form by the kidneys, or the metabolites get excreted by the kidneys. Okay? So basically whatever we take into our bodies, the output of it is basically urinary elimination. Okay? So if we take a drug and it's eliminated by the kidneys and kidney function declines, what happens to the blood levels of that drug? It's going to increase, right? And if you've got a drug that has anything but a very wide therapeutic index, right? Meaning the therapeutic dose versus the toxic dose, right? If that is anything but a huge margin and the blood levels rise, then you could potentially get into some major drug toxicity when renal function goes down. Okay? So primary route of elimination for drugs and endogenous stuff. Maintaining water and electrolyte balance. Okay? So, excuse me, normal potassium, sodium levels, normal calcium, magnesium, bicarbonate, okay? All of the phosphorus, all of these solutes of extracellular fluid that play critical roles in a variety of cell functions, those levels are actively maintained by renal function. Okay? The kidneys also secrete a variety of hormones. The kidneys are also endocrine structures. Okay? They secrete hormones that are critical for the maintenance of systemic blood pressure, right? So long-term regulation of blood pressure. The kidneys also release hormones that regulate its own blood flow. Okay? So the kidneys actively regulate their own blood flow. They also release hormones that are critical for maintenance of red blood cell production. Okay. So this high blood flow that the kidneys receive, one of the things they're doing is they are measuring the pressure constantly, they're measuring the volume going through the kidneys, and they're measuring the oxygenation of the blood moving through the kidneys. Okay? And based on all of that, pressure, volume, oxygenation, the kidneys then adjust volume, pressure, and red blood cell count. Okay? And then the kidneys also play an active role in bone metabolism, okay? Active calcium regulation, vitamin D activation. Okay? We'll get to that this semester in Patho, but for now, just take that as gospel. And the kidneys are also metabolic organs. So the kidneys also participate in the breakdown of peptide hormones and the synthesis of glucose in the fasting state. Okay. So, wide array of functions, critical functions that the kidneys play. And it's very, very clear how important kidney function is when you observe people with slow deterioration of function, and in particular when they're at sort of end-stage kidney failure. Okay? It's really a multi-system problem when the kidneys fail. So just a little bit of memory jogging. Okay? So we've got these two beautiful kidneys on either side of our abdominal cavity. Sitting right on top are the adrenal glands. And interestingly, they're actually sitting on top but slightly facing forward, right? I was sitting with a medical imaging person, an MRI tech, and they were going through this sort of cross-section of the abdominal cavity, and they showed how the adrenal gland, so if it's a side view of the kidneys, the adrenal gland is actually sitting a little bit forward, right? Which you never need to know, but. So each kidney We know that the functional unit is the nephron, right? The functional unit of urine formation is the nephron. About 1 million nephrons per kidney, right? That's what your God-given kidneys start off with. There is a normal, we'll talk about this in a second, there's a normal decline in nephron mass as you get older, okay? So you're born with 2 million, and that number slightly goes down as you age. The kidneys receive blood flow through the renal artery, okay? That blood flow, a small fraction, about 5% of renal blood flow, goes to actually just oxygen delivery to the kidneys. Okay. The other 95% is really going to the nephrons for that filtering function. So that 95% of renal blood flow moves through the nephrons and then leaves the kidney through the renal vein that then drains into the inferior vena cava and then goes back to the heart. Okay. The urine that's formed constantly, it collects in the renal pelvis and then travels down the ureters and then is stored in the bladder. Okay. When, thankfully, we choose, hopefully we choose, to void, the urine is then travels from the bladder through the urethra and then out of the body. Okay. So we'll actually look at the urinary system a little bit in a moment, but really this system, excuse me, is often described as renal urinary because renal relates to the kidneys and the process of urine formation and all of the other functions of the kidneys, while the urinary system is really about the handling of urine once it's produced. Okay? The traveling to the bladder, the storage in the bladder, and the emptying of the bladder. Okay? So inside the kidney, we know we've got two basic anatomical zones, the outer cortex, the inner medulla, right? And then in the medulla, we've got these renal pyramids. Do you remember what those renal pyramids were collections of? Did we remember? What part of those nephrons the renal pyramids were? I'll give you a hint. It's the last part. Collecting ducts, right? So those long collecting ducts that I think it's like 8 or 9 nephrons drain into a single collecting duct, right? So they all gather in that renal pyramid and drain into the renal pelvis, okay? Which is this part that's kind of this part. I don't even know how to describe it. All right. The junction between the renal pelvis and the renal pyramid is sometimes called the calyx or the cutting edge. It's just a margin. And that's a significant, it's only significant because when we look at the development of things like kidney stones, that's usually where they begin, right, in those calyces. Okay. So functional unit in terms of urine formation in the kidneys is the nephron. And we know that the nephron is composed of both vascular tissue and tubular tissue, right? So we've got a branch of the renal artery forms into the afferent arteriole, which perfuses or sends blood to the glomerular capillaries. And then at the glomerulus, you see glomerular filtration, right? The movement of fluid into the Bowman's capsule. What percentage? Can you remember? Percentage of blood flow that enters the glomerulus that gets filtered? So 20% is a really common number in renal physiology. So 20% normally is the filtration fraction, okay? So 20% gets into the Bowman's capsule, the other 80% moves on to the efferent arteriole, and then the efferent arteriole leads to the peritubular capillaries that surround the rest of the nephrons, right? Or the rest of the parts of the nephron. And it's between the nephron tubule and the peritubular capillaries that we then see reabsorption and secretion. Okay? Your textbook uses kind of odd terminology to describe reabsorption and secretion. I don't even remember the words that they used. I think it's like absorption and reabsorption is what they used. I think it's just, you'll never see those terms again. So just keep in mind reabsorption and secretion, because that's what you're going to see the rest of your career. Okay? And then that blood drains into the renal vein and then back to the vena cava. So then the tubular component, we've got the Bowman's capsule, which drains that filtrate or collects that filtrate. The fluid moves onto the proximal tubule, right? You remember in renal physiology, the proximal tubule was where really everything was happening, right? Lots of sodium reabsorption, lots of potassium reabsorption, hydrogen ion secretion, reabsorption of glucose and amino acids, and right? So a ton of reabsorption and secretion is happening at that proximal tubule. Okay? The major adjustments to the composition of urine are happening there. Then we get into this loop of Henle, leading to the distal tubule and the collecting duct. Okay? And the distal tubule and the collecting duct, the critical things that are happening there is the adjustments to the concentration of urine. Right? And then once that urine is in the collecting duct, draining into the renal pelvis, now the composition is set in stone, and that's what's going to get voided. One thing before we leave this nephron structure, glomerular filtration. Well, actually, I'll go to the next one. Yeah, that's my slide, right? So glomerular filtration, 3 basic steps in urine formation: glomerular filtration, a tubular reabsorption, and tubular secretion, right? First step in urine formation, filtration. Without filtration, you do not get urine formation. Okay? No urine production without filtration. And without urine formation, you don't have the excretion of waste. You don't have the regulation of water and electrolytes. Okay? Does anybody remember what controls glomerular filtration? What forces control glomerular filtration? I'm sorry, say that one more time. Hydrostatic pressure, right? Pushing pressure. So the one that's coming from Bowman's capsule is called Bowman's capsule hydrostatic pressure. What do we call the one coming from the capillary? Capillary blood pressure, right? So glomerular capillary blood pressure. And then there's one more pressure that influences GFR. Right, plasma oncotic pressure. Okay? So of those 3 pressures, what pressures promote GFR? Capillary blood pressure and that's it. Right? Trick question. So pressure and capsule hydrostatic pressure oppose GFR. Albumin in the capillary is pulling fluid in, right, not letting filtration happen. And Bowman's capsule hydrostatic pressure is pushing into the capillary, opposing GFR. Okay? So for all of us in this room that we're producing urine in a healthy way, it's because our glomerular capillary blood pressure is high enough to overcome those other two. Okay? And if anything changes that, we'll stop producing urine. Okay? Okay. Blood pressure control. The kidneys control both the volume of blood, the pressure of blood against the vessels, and the red blood cell and carrying ability. Those things. Blood pressure control in this long-term way is controlled by the renin, angiotensin, aldosterone system, right, which we revisited in the first fluid and electrolyte lecture, right? So if blood pressure drops, the kidneys release renin, right? Renin promotes the production of angiotensin II. Okay? It's a two-step process. Angiotensinogen becomes angiotensin I, right, as a result of renin. And then angiotensin I becomes angiotensin II with the help of what enzyme? ACE, exactly. Okay? Now, angiotensin II works in a million different ways. No, it's more like 5 ways. But does lots of things that's directed towards elevating blood pressure, expanding blood volume, okay? Including being a vasoconstrictor, right? Angiotensin II is a vasoconstrictor. It stimulates the production of aldosterone, which causes water and sodium and water retention. Stimulates the release of ADH to promote water retention. Okay? And the idea is that increase in blood pressure and volume recovers the blood pressure and helps shut the system off. Okay? So renin-angiotensin system is an incredibly important part of this. Let me, we'll talk about that some other time. Okay, so the urinary system, okay, so that's the production of urine and the regulation of blood volume and blood pressure. The urinary system involves the structures that are in place for the collection, storage, and removal of urine from the body. Okay? So the urinary system looks different, slightly different, especially in the lower urinary tract, between males and females. Okay? So the urinary tract is described as being either upper or lower, depending on where you are with respect to the bladder. Okay? So above the bladder is the upper urinary tract, below the bladder is the lower urinary tract. So urine forming from the kidneys collects in the renal pelvis. It travels down the ureters and is stored in the bladder. Okay? From the bladder, you've got the outlet is the urethra, and then urine is released from the body. So in the female urinary system, the urethra is very short. Okay? It's a very short space between the neck of the bladder and the outlet of the urethra, compared to males, where the outlet of the bladder leads to this longer urethra that travels through the prostate gland. Okay? The prostate gland fully encapsulates or surrounds the urethra. And then from the as it moves out of the prostate gland, the urethra moves through the shaft of the penis until it exits through the meatus. Okay? Or the outlet is through the meatus. The prostate gland becomes a very important structure, significant structure with respect to the male urinary system, because it allows for a few things. So the prostate gland, number one, because the urethra moves through it, and the prostate gland actually tends to enlarge as men age, normal, totally normal. All men will have some prostatic enlargement as they get above 50 or 60 years old. It doesn't have to create any kind of symptoms, but if it does get larger than a certain degree, it will create symptoms. But if it enlarges beyond a certain degree, it tends to, because the prostate gland is encapsulated by fibrous tissue, it tends to squeeze down on the urethra and create symptoms interfering with urinary elimination. Okay? But with normal function, one of the things that the prostate gland allows is in the process of the male ejaculation cycle, the prostate gland actually clamps down on the urethra and prevents retrograde movement of semen into the bladder. Okay? Because semen and urine both leave through the urethra, the prostate gland kind of clamps down on the, so semen, this is a long story. So just before ejaculation, the fluid from both the prostate gland and the seminal vesicles enter the urethra through the shaft of the penis, and then the prostate gland clamps down, and then it's ejected, right? So ejaculation actually happens after that. So it fills the urethra, clamp down, and then it's expelled. So that clamping down prevents retrograde ejaculation, and it also means that ejaculation and urination cannot happen at the same time. Okay? So little tidbit on the male urinary system. Okay? The length of the urethra also explains why women are more prone to urinary tract infections. Right? Urinary tract infections are almost always ascending in nature, and so it's just a shorter trip, right, for females than it is for males. So if we look at the bladder, and I just chose the female bladder because I'm biased and it's smaller on the slide. We see some basic structures with respect to the bladder. And some of the key structures for you to really feel comfortable with is the detrusor muscles. So the muscle layer of the lining of the bladder is called the detrusor muscle. Okay. You've got the spaces where the bladder and the ureters meet. Okay. Ureteric orifices is what they are called. You have the neck of the bladder, and that's where the bladder and the urethra meet. And then within the urethra, you've got internal urethral sphincter muscles, okay? And you have external urethral sphincter muscles. The internal urethral sphincter muscles are non-voluntary, so it's smooth muscle and it's controlled by the autonomic nervous system. The external urethral muscles are actually part of the pelvic floor muscles, and that's skeletal muscle that's voluntarily controlled. Okay? So it's primarily through the external muscles that control of timing of urination is allowed or made possible. Okay? Because you have to voluntarily relax those. So the bladder, as I've poached from your textbook, plagiarized from your textbook, the bladder is a reservoir for urine. The filling and emptying of the bladder is really mediated by a coordination of sympathetic and parasympathetic control. And it really is a coordination of both the detrusor muscles of the bladder and the internal and external sphincter muscles. Okay? That's what allows for you to retain urine and also void. Okay? So the term micturition is fancy talk for urination. Okay? So micturition or urination is described as occurring through a cycle that involves the storage phase versus the voiding phase. Okay? So during the storage phase, urine is retained, right? The bladder relaxes to accommodate the urine. The sphincter muscles are constricted to keep the urine retained, and the net effect is storage. In the voiding phase, the detrusor muscles, the bladder contracts, the sphincter muscles relax, and so that the net effect is voiding, okay, an emptying of the bladder. So with this phase, if we start off with an empty bladder, okay, what we see is that the bladder is relaxed, okay? The urethra or the internal sphincter muscles are constricted, and the pelvic floor muscles or the external sphincter muscles are also constricted. Okay? As you start to collect urine, as the bladder starts to collect urine, you get to a certain volume in the urine, about 150 to 200 mils. Okay? And it's at that volume that you just first start to sense the urge to void. Okay? Now, the functional capacity, basically the max volume of your bladder, is somewhere between 400 to 600 mils. Okay? So, you know, you're not even halfway there when you get to this like sensation, oh yeah, I could void. I can give or take it, all right? And at this stage, right, in this sensation to void, your bladder is still relaxed, and the level of constriction of the urethral sphincters, the internal ones, actually the level of constriction increases, right, to help retain that fluid. And your pelvic floor muscles are contracted as well. Now, when you choose to void, okay, and as this bladder fills more and more, the level of constriction of that sphincter increases, and desire or urge to void also increases. So when you void, your bladder contracts, the sphincter muscles, internal sphincter muscles relax, the pelvic floor muscles relax, and then voiding happens. Okay? And now you're back to this bladder filling phase. Now, this voiding cycle, this micturition cycle, is controlled by the sympathetic nervous system and the parasympathetic nervous system. Okay? When you are in this bladder filling phase and the bladder is relaxed, the internal sphincter is constricted, the external sphincter is constricted. At this point, your sympathetic tone is increased, right? And the parasympathetic input is inhibited. Okay? So sympathetic stimulation to the bladder causes relaxation. Sympathetic stimulation to the sphincter muscles causes constriction. Okay? And the parasympathetic input is actually inhibited. Now we get to this sensing the voiding. What do you think is happening to the sympathetic stimulation? What's that? No. Did you say it decreases? It actually increases, right? Because in order to accommodate this urine, the bladder has to remain relaxed, right, which is a sympathetic function. And the internal sphincter muscles have to constrict even more, which is also a sympathetic function. Yeah. When you're running, you don't want to pee your pants. That's right. That's right. I don't want to pee my pants when I'm running. That's right. Unless I don't feel like stopping, then, you know. No, I'm just kidding. Just kidding. So, and the parasympathetic input is even more inhibited. Now, when you're ready to void, everything switches, right? Sympathetic input gets inhibited, and parasympathetic input increases. Parasympathetic stimulation contracts the detrusor muscles, contracts the bladder. Okay? Parasympathetic stimulation relaxes the internal sphincter muscles. Okay? And then you voluntarily relax your pelvic floor muscles. Yeah. Do you mean that like in a big picture way, or do you mean that in a mechanistic way? Like why?
Why is the bladder contracting? Like I understand in theory,
Yeah.
but how is that happening?
It's a really good question, okay? So using the same neurotransmitter, you can actually get completely opposite effects depending on what? The receptor that's on the cell, right? So norepinephrine or epinephrine binds to alpha receptors on muscle, and you get constriction. If they bind to beta receptors on muscle, you get relaxation. So there's a different receptor subtype between what's on the detrusor muscle and what's on the sphincter muscle. Okay? Right? So in this voiding phase, the net effect of detrusor contraction and sphincter relaxation is voiding, right? So that is, so sort of the quick and dirty way to remember this, right, is parasympathetic. When the parasympathetic nervous system wins, you void. P equals P, yeah. That's brilliant. That's brilliant. Little p, big P equals little p, that's right. So, excellent. But yes, so when you are voiding, that's a parasympathetic function. When you are retaining urine, that's a sympathetic function, okay? And then basically you can work out in your head, if you need to retain urine, then you obviously need to relax the bladder and constrict the sphincter, and the opposite for voiding, okay? So if you have someone with overactive bladder, right, so they have urinary leakage because of overactive bladder, which means that their detrusor muscles are spasming randomly, okay? What kind of drug is going to improve that situation? So let's work through it. So the spasm, okay, is mimicking this voiding phase, right? And the P equals P. So that's a parasympathetic function, right? So if we want the opposite of that, then we, as Jennifer said, an anticholinergic drug is going to improve that. Make sense? So just remembering that like who controls what phase will help you work through issues like that. Okay? All right. Yeah.
What happens when someone's like running a race or something, like it's pretty common to let go of your bladder or let go of, is that like your body becoming to the sympathetic?
So there's a couple things that could be playing into it, right? Muscle exhaustion is definitely a possibility. Excuse me. Because ultimately, if you've got a full bladder, what's the only thing that's really keeping you from voiding is primarily your pelvic floor muscles, right? So if you have muscle fatigue, that can be a problem. The other thing is, when you are running, the abdominal muscles are constantly pushing with every step against your pelvic floor muscles, which can be a challenge, right? Like, so, you know, you don't, like, if you jump up and down when you need to, not a good idea. And then there is extreme stress responses, right, tend to actually have the opposite effect that moderate sympathetic responses have. So in terms of voiding. So what you'll find is, like, when people are in extreme stress responses, it's almost like a vasovagal kind of thing, where instead of urinary retention, you actually have emptying of the bladder. So all of those things could be playing into that. Yeah. Yep. Yeah. Deep breathe, cross your legs. Yeah. No, what you're really doing is focusing, right? No, really. I mean, like, when you're deep breathing and all that stuff, you're really just trying to, like, you're just trying to focus on, like, yeah, and on not peeing, exactly. Yeah, yeah. No, and the thing is that the parasympathetic nervous system is also a fairly discrete system. So what's happening parasympathetically to your bladder is not necessarily what is happening to other parts of your body, you know? The sympathetic system tends to happen a little bit more globally, but the parasympathetic is a little more discreet. Yeah. Okay. So that's the dynamics of voiding and micturition. So, we talk a lot about the gerontological implications or perspective in many of these sections. And in terms of the renal system, there is a significant change as you get older. So the elderly have alterations in urinary function, renal and urinary function, that are fairly predictable and will happen in both healthy and unhealthy or people who suffer from chronic conditions. And for those who suffer from chronic conditions, that normal aging of the renal and urinary system only worsens their conditions, okay? So some of the things that happen as your renal system ages, a really stark thing that happens is that you actually lose nephron mass, okay? So as you age, there is really anywhere from a 30 to 50% decrease in the number, size, weight, and function of nephrons. Okay? So you literally can lose half of your healthy nephron mass just as a function of aging. So if you think about some other pathological condition happening underneath that, it's only going to accelerate that loss. Okay? So some of the things that we see with a decrease in size, weight, and number of nephrons and decreased blood flow, what we see is a decrease in GFR and a decrease in the ability to excrete waste and reabsorb essential solutes, okay? Which means that your ability to excrete drugs and drug metabolites go down, right? So what will that do what will that do to the half-life of the drug? It'll increase it, okay? So drug half-lives tend to increase, which means doses need to get lowered, okay? You have a decrease in your ability to secrete or get rid of hydrogen ions, which makes you vulnerable to acidosis. Okay? You have a decreased ability to concentrate urine, which means that you are more vulnerable to dehydration. Okay? You have an increase in the renal threshold for glucose, okay? Meaning that blood glucose levels can actually get higher before they spill over into the urine compared to someone with a healthier kidney function. Okay? And the implication for that is for those who are elderly with diabetes, they can actually become hyperglycemic much faster, and their peaks can be much higher. Okay? Hyperglycemia, yeah, exactly. Okay. As you age, the strength of your innervation to your bladder, so the sympathetic and parasympathetic tone to your bladder goes down, and your bladder capacity goes down, which means that you have a decreased sensation of filling. You're less aware of the filling of your bladder, okay? Your muscles become weaker over time. You have changes in the structure of the urethra, including a decrease in sphincter tone, which altogether increases the risk of incontinence, okay? Excuse me. And then, especially for men, with respect to the changes in the prostate, you can have a harder time initiating a stream of urine. Okay? And then, as you get older, as you age, your diurnal patterns with respect to urine formation start to change, which means that, so normally when you're young, I'm always amazed by this because my daughter is going to be 4, and she's been potty trained for like the last year, and like she does not pee in the middle of the night, right? I know. Most of the time, she does not pee in the middle of the night. But I get up like 3 times to pee, so like, I have no idea how that works. But it's because as you get older, the normal pattern, which is that your blood pressure drops when you go to sleep, and your urine production goes down when you sleep, right? And then when you're awake, your blood pressure is higher, and your urine production rate increases. So that tends to change a little as you get older, so you're more likely to have a higher urine production at night and have a greater need to get up in the middle of the night to urinate. Okay? So that increased nocturia. Okay. We go to 2 today, right? We go to 2. Okay. Are there questions, or is it just a little? Yeah. It's a really good question. So whether you're hypertensive or not, your blood pressure, there is a diurnal pattern to your blood pressure. So even if you have a normal blood pressure, daytime blood pressure, you will have, depending on how low, you will have up to a 20% drop at night. That's just normal. And that 20% drop helps reduce urinary production. Some individuals have less dipping at night, and then as you age, the dipping becomes less pronounced. So it's a change in that sort of diurnal regulation of a lot of things in your body. Okay. So keeping in mind this idea that, as people get older, their urinary function and renal function changes predictably, no matter what else is happening with their health status, is helpful to keep in mind that when you are evaluating patients or when you're thinking about patients, it's important to consider health histories when you think about their potential for renal function, okay, or potential for vulnerability for renal disorder, okay? So things that are important to think about in terms of health history, as I mentioned, advanced age. So if you're older, you already are more vulnerable to all of these renal disorders, okay, including renal failure. You're just already closer to that threshold. Somebody who has diabetes is more vulnerable to chronic kidney disease, and they're more vulnerable to changes in the neurological or nervous control of bladder function or the control of the urinary system. Okay? So we didn't get to diabetes yet in patho or here, but basically diabetes involves hyperglycemia, and hyperglycemia is damaging to 2 tissue types the most, vascular tissue and nervous tissue. Okay? If you have a diabetic patient, you already can assume that there's a renal vulnerability. Okay? And if you've had somebody who's been diabetic for a long time, you can already assume that they may be more vulnerable to incontinence, okay, because of that nervous tissue effect. Somebody with hypertension, this is another big one, right, because diabetes and hypertension are like the American dyad, right? It's incredibly common in developed nations. It's not just us. But if you are hypertensive, high blood pressure is also very damaging to blood vessels, and all of the capillaries in the glomerular capillaries in the kidneys, they tend to experience chronic damage when you have chronic hypertension. Okay? So someone who has hypertension, again, especially if it's long-standing, again, you can assume that they are very vulnerable in terms of renal function. Okay? Now you have a patient who has diabetes and hypertension, which about half of hypertensives also have diabetes. Okay? And diabetes is a huge risk factor for hypertension. Okay? So having both of those diseases is very common. So having both of those diseases, now you already know that this patient is very vulnerable. Okay? Pregnancy. I'm going to jump around, right? So pregnancy, bless you, that was the most adorable, sneeze. Yeah, they're all used to it. I've never heard that before. Pregnancy does a number on you in many ways. But pregnancy does, in terms of urinary function, so pregnancy tends to, the hormones of pregnancy tend to cause relaxation of the bladder, okay, which increases the likelihood of urinary retention and increases the risk of UTIs. Okay. As the baby gets larger, sometimes you can have compression of the ureters, right, between the kidneys and the bladder, and that can cause urinary retention and infection. And pregnancy also is a huge challenge or stress on the pelvic floor muscles, right? Both before you deliver and if you deliver vaginally, your pelvic floor muscles are never quite the same. But you have an increased risk for what's called stress incontinence, okay? And stress incontinence is the leaking of urine during doing things like coughing or sneezing, or laughing really hard or whatever, okay? So pregnancy really affects all of those things. You are also more likely to see trace amounts of protein in the urine of a pregnant woman, and that's not pathological, okay? Higher than trace amounts, that's very significant, just preeclampsia. Trace amounts and a woman who's pregnant will often void much more frequently, okay? And that's from the get-go, from the beginning. So different aspects of a person's health history excuse me, is very, very helpful in understanding their vulnerabilities and can really help you better care for them in terms of what their needs are. Okay. So there are some terms that's used to describe alterations in voiding patterns that you should get familiar with. Many of them you've already have heard before, and many of them are very indicative of certain disease processes. So anuria is a term that literally, as translated, means no urine production, even though by definition, it's any urinary output less than 50 mils per day is anuria by definition. And it's you see anuria with acute or chronic renal failure, okay, or complete obstructions. Things like hematuria. Okay, I'm just jumping around, but I want you to read through this. You don't have to commit all of it to memory. But hematuria refers to the presence of blood in the urine, and sometimes that's very easily visible. Right? So sometimes the blood is visible, and sometimes the blood is not visible, but there are trace amounts of red blood cells. So hematuria can accompany things like cancers of the genitourinary tract, acute glomerulonephritis, trauma to the kidneys. Actually, that's a very common thing where you have trauma to the kidneys and then hematuria as a result. My graduate mentor was a rugby player and said that he had experienced many hematuria weekends after rugby matches. So, yeah, you'd think you'd stop, but he was British. So a lot of different etiologies are associated with hematuria. Some renal and urinary diagnostic tests can cause hematuria after the fact, and it's sort of there's a normal amount of hematuria that can be expected. Hesitancy refers to a delay or a difficulty initiating voiding. You see that with things like BPH or benign prostatic hyperplasia. Oliguria, a decline in urinary output. Polyuria, an increase in urinary output. Urinary urgency is this very sudden, strong desire to void, this sort of feeling of imminent loss of bladder function that you see with things like infections. You also see that with BPH as well, the benign prostatic hyperplasia. Okay. So a lot of different changes in voiding patterns are predictable of different disorders. Okay. There's a wide variety of diagnostic studies or diagnostic tests to evaluate function of the urinary system. And they really vary from very simple things like urinalysis, looking at sort of dipstick analysis, things that are very, very simple. Urine culture, looking for the bacterial growth in urine to confirm UTIs or pyelonephritis. Okay. Imaging studies like ultrasonography to evaluate the kidneys, CT scans or MRIs and nuclear scans. Biopsies can be important for the suspected renal cancers. Excuse me. Cystography, I'll show you a picture of this in a moment. Cystography is the visual examination of the urinary tract, the urethra, and the bladder to evaluate for things like strictures or other obstructions, okay, tumors, whatever. And then there's a whole host of renal function tests, many of which we've talked about before in patho. So there's renal concentration tests. So there are certain things that reflect your kidney's ability to concentrate urine, things like urine-specific gravity and urine osmolarity. Okay? Especially if you can compare that to blood osmolarity, then you get a good sense of what the renal concentration potential is for the kidneys. 24-hour urine collection allows for the evaluation of creatinine clearance rate. And what does that help us measure, creatinine clearance rate? GFR, okay? So creatinine clearance rate helps us measure GFR, and GFR helps us evaluate the status of the kidneys in terms of their urine production and the healthy nephron mass. And then blood tests or serum tests, blood creatinine, blood urea nitrogen, and then the comparison of blood urea nitrogen to blood creatinine. Okay? So what direction does creatinine go when GFR and renal function goes down? It goes up, right? So you see elevations in blood creatinine, you'll see elevations in BUN, okay? And then a change in the BUN to creatinine ratio depending on the specific cause of the problem. So cystography, what I was describing earlier, this is just an image of what this looks like. So it's a cystoscopic evaluation. There's a imaging tube that's inserted into the urethra that has it has a little end of it, and it allows you to visualize the urethral canal. It allows you to visualize the neck of the bladder and the bladder itself. So when people have voiding problems, one of the things it could be is a stricture that actually through this mechanism or through this test you can, there's also like a little tool at the end of this thing that you can break up a stricture if necessary. There's also, this is obviously the male urinary system, you can actually, with benign prostatic hyperplasia, one of the things that's done is making a small incision in the capsule that surrounds the prostate in order to relieve the pressure so that the prostate can expand outwards instead of crushing down on the urethra. And then examining the bladder for any abnormalities as well. Okay. I believe so. I believe so, yeah. Yeah. Yeah, I mean, this whole picture doesn't look fun, I'm sure. But it's a fairly common exam. It's something that's done under general anesthesia. Yeah. Yeah, general anesthesia, you're totally knocked out. And the reason why this image comes up and the reason why this is something that's set aside is because this is something there's a lot of nursing interventions that are involved in supporting someone who's going through this. There's a lot of pre-op care because they are undergoing general anesthesia. For example, what's one of the parts of pre-op care? NPO, right? So at least 12 hours of no food or water, right? So this is a pretty invasive procedure, and then after the cystography or cystoscopic test, hematuria is very common just because of minor trauma to the urethra, and you cannot discharge them. It's done in a hospital, obviously, and you can't discharge them until they do what? Void, right? Because you want to ensure that there's no obstructions. Exactly. So there's a lot of very specific assessments and interventions and nursing diagnoses involved with the cystoscopic evaluation. Okay. Yes. I think that the that they will do if they find something, you know, so the breaking up of the stricture and the, you know, it's the, yeah, I mean, it's yeah, that's, I mean, it can't be all that much bigger, right? Yeah. 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 I mean, it's a little like endoscopy, exactly, where it's interventional at the same time that it's diagnostic, exactly. Yeah, and that I'm assuming that that's the reason why it's a general anesthesia. I also think that the general anesthesia, the muscle paralysis involved in the general anesthesia is necessary, I think, to probably allow for the passage of the scope, you know, because there is smooth muscle in the urethra and the, you know, so. Yes, yeah, exactly. Yes, ma'am. I didn't hear you, I'm sorry. Yes, you're not going to discharge them until they void, exactly, because you want to make sure that there wasn't any hematomas or any kind of obstruction that's or neurogenic problems that's, yeah, preventing voiding. So in terms of the physical exam, there's a couple of things that are done. You can palpate the kidneys. So it's interesting. Your textbook says that normally the kidneys are not palpatable unless they are enlarged. So it's one of those things that if you can palpate the kidneys, it's suggestive of enlargement and pathology. Okay, and you know, the person is the picture depicts this technique for palpation of the kidneys. Also, palpation and percussion of the bladder is also often done. So what you're actually looking at is the difference between an empty bladder and a full bladder. So where you palpate with respect to the umbilicus and where you feel the bladder lets you know how distended it is, right? Now, so you can palpate the bladder, and then what's also done is percussion of the bladder. So it's actually easier to palpate a full bladder than it is to palpate an empty bladder, because the empty bladder is so close to the pubic bone that it's very difficult to palpate it. Of course, be careful how hard you press on a full bladder. Now, if the person has, so one of the things that this is useful for is evaluating for urinary retention. So urinary retention meaning that the person attempts to void completely, but there is still retained urine. Okay? And that kind of urinary retention increases the risk of infections dramatically, right? So if you have the person void and you percuss over the bladder, sound. Okay? So after voiding, if you can palpate it's very suggestive of retention. Okay? I am sure that there is. I'm not aware of it. Yeah, yeah. Are you guys doing this in physical assessment or the lab? You did percuss the bladder? No, you didn't percuss. You know, some of these like physical assessment things, what I always noticed was that a lot of these physical assessment things, it's like you have to be like a practicing clinician for like 20 years to be able to like know what a percussion over the bladder sounds like, right? Or so this isn't necessarily, this is sort of like a very, very skilled physical assessment technique. Yeah. Which makes a lot of sense, right? Yeah, exactly. That's a lot easier to detect than difference in tone. But what isn't necessarily a very sophisticated physical assessment maneuver is identifying a location of pain that can be very suggestive of kidney pathology. So what you often hear is flank pain in reference to kidney visceral pain. And the specific location where you see this, it's called the costovertebral angle, but it's the space between the spine and the 12th rib. Okay? So pain in that area, often bilateral, but it doesn't have to be necessarily depending on the problem, is highly suggestive of being of renal origin. Okay? And it often won't be a superficial pain, it'll be a very deep pain, but you might see tenderness on palpation in that area with renal problems. So when you have patients that are undergoing this renal urological diagnostic testing, there are some key nursing assessments that you see. So you assess the level of patient knowledge. What do they understand about the test? What do they understand about why they're getting the test, what it's going to be like? Psychosocial, emotional factors, fear, anxiety. Do they have support with them? Not have support with them? They're under general anesthesia. Do they have somebody to take them home? Do they not have somebody to take them home? Urological function. So what is the status? Are they incontinent? Are they fully continent? Fluid intake. So if they're coming in for this cytoscopic evaluation, did they actually not consume fluids, or have they consumed fluids, right? So what was their fluid intake? If they're undergoing things like a CT scan, right, with contrast dye, did they drink enough before they came, right? Because that requires a significant amount of fluid consumption. With ultrasonography, you want a full bladder, right? So how soon did they drink and how much? Okay. Do they understand that they need to feel like their bladder is full before they go into this test? And that might be kind of uncomfortable, but they need to not void until after the test. Level of hygiene, make sure that they understand if there's any instructions in terms of post-care or pre-care that need to be addressed. The presence of pain or discomfort, and maybe administering a PRN analgesic if that's prescribed, and any known allergies, especially with respect to things like anesthetics and contrast dyes and things like that. Okay? So you're going to assess for all of these things, and then there's a couple of very common nursing diagnoses that are associated with caring for someone with who is undergoing diagnostic testing. Three basic ones: knowledge deficit, right? They don't know enough about the test, why they're getting the test, what are the possible outcomes of the test. Okay? Pain. Some of these tests are uncomfortable, and support them in terms of their pain. And fear. Some of these tests, they understand the test, they're terribly afraid of the test, and and they also could be quite embarrassed about talking about it. So, key nursing diagnoses. So, common interventions to address these issues: encouraging fluids unless contraindicated. In general, unless they are specifically told not to consume fluids, any kind of diagnostic test with the renal and urinary system, good basic care is encouraging fluids, okay? Because it encourages the removal of whatever substance that may have been involved in the diagnostic test. Oh, I'm sorry. I thought somebody was asking something. Teaching patients about different techniques that can reduce their discomfort, things like Sitz Baths post-test. Everybody know what a Sitz Bath is? Yeah. So the Sitz Bath can be very soothing if you've gotten certain invasive testing. Relaxation techniques to reduce anxiety. Administering analgesics and antispasmodics as prescribed, assessing voiding, and providing instructions related to voiding and hygiene. There are certain voiding patterns that, voiding habits that patients can get into, specifically not voiding completely, that can actually increase the likelihood of UTIs. So, believe it or not, some people, sometimes it's important to talk about that. Providing privacy and respect, and this information is from the chart in your book. Okay. So, when you have a patient with kidney disorders, the gamut of kidney disorders, you have a lot of common problems that can come up. Okay? When the kidney function is altered, you have a lot of common problems. By far, a ubiquitous problem that people with kidney disease experience are fluid and electrolyte disturbances. Okay? So I know that you've already done fluid and electrolyte balance a week or two ago, so I'm not going to get into it very deeply. But these are the disturbances that are commonly found with kidney disorders. Okay? Fluid volume deficit or excess, depending on the problem. Okay? When you talk about kidney function going down, you often talk about urinary output going down, and then which one are they actually going to have? Fluid volume excess, exactly. So if urinary production goes down, it's going to be fluid volume excess. Fluid volume deficit is something that you can see in certain kidney disorders, things like Nephrotic Syndrome, and we'll talk about that in a little bit. Excuse me. Sodium imbalance, whether it's deficit or excess, potassium imbalance, deficit or excess, okay? When sodium levels are altered, what do we worry about? Right? Level of consciousness and neurological function. When potassium levels are altered, we worry about the heart, right? Calcium deficit or excess. Calcium levels going up and down are going to greatly affect the level of excitability of muscle and nervous tissue. So when you read a question and they're talking about deep tendon reflexes, right? It's in relation to fluid and electrolyte imbalance, they're usually talking about calcium, okay? Because that calcium level changes the excitability, and it's going to either, a decrease in calcium increases excitability, so you have exaggerated deep tendon reflexes, and an increase in calcium decreases excitability, so you have dulled tendon reflexes. Okay. Bicarbonate deficit or excess, the kidneys are responsible for reabsorbing bicarbonate. okay? And secreting acid. So depending on what's going on with the kidneys, you can end up with either a bicarbonate deficit or a bicarbonate excess. Protein deficit, what kind of disease, what kind of damage or problem causes a protein deficit in someone that's renally, what's that? Liver problems, but what if the liver's fine, it's a renal problem? Miriam, what'd you say? It's something different, but it's not unrelated completely. So it's a glomerular problem, right? Because it's the glomerular membrane, it's the glomerulus that's supposed to keep the protein in the body and prevent it from being lost through the urine. Okay? So if you see protein in the urine, it's because there's damage to those glomerular membranes, and they're leaking protein. Okay? Excuse me. And we're going to talk about this syndrome, but nephrotic syndrome is all about that. It's all about the loss of albumin because of damage to the glomerular membrane. Magnesium deficit or excess. Magnesium is also one of these electrolytes that are incredibly, has a huge impact on the excitability of cells. So high magnesium tends to decrease excitability, and low magnesium tends to increase excitability. Okay? A way to remember this, or the thing that I always think about, is people with chronic alcohol abuse, so alcoholics that have a real alcohol addiction, tend to have low magnesium levels. And when they stop drinking, they're very prone to like seizures, right? Because the magnesium is very low. So the brain excitability is very high. Okay. And then the phosphorus deficit. Phosphate goes down when your body becomes acidic. So if these are not participating in acid-base balance and you're acidotic, your phosphate levels can go down. Okay. So some common disturbances that we see with kidney disorders. And then this is actually, that list was taken from this table. That list from the last slide was taken from this table. And in this table, it outlines all of these things. It talks about some manifestations and some general management strategies. And I'm not expecting you to memorize this. This is just for your reference to know that this is there in that chapter. Okay. The renal section of this, I'm going to support you guys a lot through this renal section, because to have 3 chapters, 1 lecture, and like next week you got a test. I'm going to be distributing study questions for you guys to work on this weekend that help you kind of focus where to focus. Okay, because I know this is massive, but you know, think of a lot of what I'm presenting as something that, like, keep it and it's like for your future practice and for reference, okay? When I was preparing this lecture, I was like, are you kidding me? Is this not done yet? Oh. Is that how you feel? Yeah, yeah. You know, I'm sick, I got 2 sick kids, and it's like, you know, you like flip through and like, how many pages do I have left? Heart just sinks. You realize you've got like 30 more pages to go through. Yeah. So why don't we take a break? I see some people. So let's, yeah. Which? 10 after, 10, 15 after, okay?
right?
All right, everybody. So why don't we continue? Excuse me. All right, guys. So talking about kidney disorders. So talking about kidney disorders, we talked about fluid and electrolyte imbalances that are common to individuals with kidney disorders. So kidney disease, it can either be acute or chronic. And acute kidney injuries, we'll talk about that. There's a variety of, or rather there's a spectrum of kidney injury that is sort of mild and acutely impairs kidney function, and then is more severe and actually causes acute kidney failure. But chronic kidney disease will always have a very slow onset. It will have a phase, sort of a preclinical phase that's fairly long before you have any sort of observable change in or measurable change in kidney function. Okay? So with chronic kidney disease, there's some sort of underlying pathology that is slowly damaging the kidneys. Okay? Slowly damaging the nephrons, causing nephron loss, and a slow decline in kidney function. So the causes of kidney disease, these 7 things are in order of most common cause to least common cause. So number 1 and 2, diabetes and hypertension. Okay? So diabetic nephropathy, which is the diabetic kidney disease, or the kidney disease caused by diabetes, is really the number 1 complication of diabetes, long-term complication. Okay? So diabetes is the most common cause of chronic kidney disease. Number 2, glomerulonephritis, which is inflammation of the glomerular capillaries. And the inflammation can either be acute or it can be slow and chronic, okay, depending on the cause. Pyelonephritis, which is an infection of the kidney itself, the kidney parenchyma itself. Pyelonephritis is almost always ascending in nature, so it almost always comes from the urinary tract and spreads to the kidneys. Polycystic kidney disease, we talked about this in patho. This is a hereditary or genetic disorder that the main forms of it are genetic. There's an autosomal dominant and autosomal recessive, and the autosomal recessive is associated with onset at infancy, autosomal dominant onset in adulthood. And it's this condition where people have this accumulation of fluid-filled cysts that replaces the parenchyma of the kidney. Okay? And it slowly causes a decline in kidney function. Hereditary or congenital problems other than polycystic kidney disease, and then renal cancer. So by far, diabetes, hypertension, glomerulonephritis, much more common than the rest of them. So with chronic kidney disease, and we talked about this also in patho, you have some sort of slow progressive damage, or you have some acute damage that sets the ball rolling for a slow decline. So what happens is something happens to reduce healthy nephron mass, and the remaining nephrons start to hypertrophy and hyperfiltrate to compensate for the loss. Okay? And that increase in functional demand represents injury that causes inflammation and progressive loss over time. Okay? So you have some initial loss of healthy nephron mass. The remaining healthy nephrons hypertrophy and hyperfiltrate. Right? That represents an injury which causes inflammation and loss over time. Now the stages, there are 5 stages identified in chronic kidney disease, and they are really defined by the status of GFR as measured by creatinine clearance rate. Okay? So the stages are defined by the status of GFR as measured by the creatinine clearance rate. So a normal GFR is approximately 125 mils per minute. Okay? A normal GFR for an adult is 125 mils per minute. Now, excuse me. In stage 1 and stage 2, there is really barely a decrease in GFR. Okay? There's really barely a decrease in stage 1 and 2. There is certainly a decrease. It's very, very, very small. And it's because of this compensatory phase, right, of this early chronic kidney disease. Okay? The healthy nephrons are compensating, hyperfiltrating to maintain a near normal GFR. Now, when you start to get into stage 3 and 4, you start to see much more significant declines in GFR. Okay? Until you finally, at stage 5, you really have GFR is equal to or less than 15 mils per minute. So you went from 125 mils per minute to 15 or less mils per minute. Okay? And as you can imagine, at stage 5, there's almost no kidney function to speak of. Okay? And so now treatment is really focused on renal replacement therapies, like dialysis, like transplantation. Okay? Now, as this kidney disease progresses from stage 1 to stage 5, you will see increasing symptoms, increasing severity of symptoms. Okay, and we'll talk about what those symptoms are. You'll see elevations in plasma creatinine, okay, elevations in BUN. There's a couple of terms that's used to describe that elevation in creatinine and BUN. There's azotemia, there's uremia. Okay. So there's a couple of terms that come up when you start talking about moving up in the stages of chronic kidney disease. So some of the causes. Okay, so we're going to talk about some of these disorders that cause chronic kidney disease. Nephrosclerosis. Okay, so the term sclerosis sort of is it translates as a hardening, right? So nephrosclerosis is a hardening of the renal artery, and it's most commonly caused by prolonged hypertension and diabetes. Okay? Most commonly caused by prolonged hypertension and diabetes. Now, what precedes arteriosclerosis? What precedes that? What's that? Hypertension and diabetes. And hypertension and diabetes represent an injury, right? It represents chronic endothelial injury that leads to atherosclerosis, which then leads to arteriosclerosis, right? So just connecting this to what we learned in the cardiovascular system last semester with atherosclerosis and plaque formation, okay? So nephrosclerosis is really this hardening, right, this fibrosis of the renal artery. Okay? And what happens when the renal artery undergoes this change is that you end up with a decline in renal blood flow and necrosis of tissue. Okay? So it's a major cause of chronic kidney disease and end-stage kidney failure. This is really the reason why diabetes and hypertension are the leading causes of chronic renal failure. So nephrosclerosis is described as either being benign or malignant, which, you know, the terms benign and malignant doesn't mean one's good and one's bad. Both are bad, but it's, you know, one's early and one's late, okay? Or one is less severe and more severe. So malignant, benign nephrosclerosis is the less early. Malignant nephrosclerosis is a significant, most often associated with significant hypertension, where the diastolic blood pressure is above 130. Excuse me. It can occur in young adults. It's twice as often occurs in men compared to women. And that decline in renal blood flow as a result of the hardening causes necrosis of the kidneys, slow necrosis of the kidneys, and eventual replacement of the kidney parenchyma with fibrotic tissue. Okay. So this is one route to getting to end-stage renal failure. Now, the next two syndromes, okay, they are not disorders per se, okay? They are syndromes, meaning that they are a collection of signs and symptoms that occur as a result of potentially a variety of causes, but it's sort of this phenomenon that happens often in kidney disease. Okay? So acute nephritic syndrome. So there's nephritic syndrome and then there's nephrotic syndrome. Those are the two syndromes we're going to talk about. Nephritic syndrome or nephritic syndrome and nephrotic. Nephritic, it's inflammation. Okay? It is an acute inflammation of the glomerulus, of the glomerular membranes. Okay? Otherwise known as glomerulonephritis. Nephrotic syndrome is something else. Okay? Glomerulonephritis, inflammation of the glomerulus, it can be caused by a variety of things. Okay? One of the more common causes is a type 3 hypersensitivity reaction, which was the hypersensitivity reaction where your body produced antibodies against some pathogen, and then in the aftermath, there's all this shrapnel, right? circulating, these immune complexes circulating. And when your body tries to clear that shrapnel, it gets stuck in the glomerular membranes. And it causes inflammation and damage. So very commonly, this is a great example of this is this post-streptococcal glomerulonephritis. Okay. So sudden onset of a very severe sore throat. Okay. You look down your throat, there's these little white spots on your tonsils. You got swollen lymph nodes. Okay. You've got a strep infection in the back of your throat. Okay. That strep bacteria, if you don't get treated by with antibiotics early with a strep infection, your body starts to produce antibodies against the strep. And then what happens is that shrapnel phase, right? So as your body clears the strep infection, you have all of these lysed bacteria, right, bits and pieces of cell wall attached to antibodies, right, those immune complexes. And they start to get deposited around your body. They deposit themselves in your skin. They deposit themselves in your joints. And they deposit themselves in the glomerular membranes. Okay? So you see rashes and hives. You have joint pain. And you have glomerulonephritis. Yes, ma'am? What's interesting is it's not an inappropriate response. That's the thing. The antibodies are against this harmful pathogen, right? It's just the tendency for, it's very pathogen specific, right? So it's the fact that these streptococcal bacteria have these really elaborate cell walls that then the antibodies get attached to. And it's really just this difficulty your body has in clearing the aftermath of an appropriate response. Yeah, that's really, the inappropriate response is really just when it gets stuck in a place, it triggers inflammation. That's the sort of inappropriate part of it. Yeah. Yes? I'm sorry, say that one more time. It's not 100%, right? It's not that anybody who isn't, that doesn't get early treatment, but I don't know what the probability is, but that's usually what the presentation history is, that it's a untreated streptococcal infection that proceeds into this, yeah, inflammation. Okay. Now, the inflammation, right? So the immune complexes get deposited in the glomerular membranes. You have this inflammation, and then the inflammation, you get, you know, this thickening of the membrane because of the edematous part of the inflammation, and it causes a decrease in GFR. Okay. And with that decrease in GFR, you get all of the symptoms that accompany that, right? So you get fluid volume overload, you get a decrease in urine production, you get an elevation in creatinine. Okay. So in the post-strep glomerulonephritis, it's an acute condition, right? It's something that's going to happen very precipitously. This is going to be an example of acute kidney injury leading to potentially intrarenal failure, okay? Intrarenal kidney failure. Okay. Now you can see nephritic syndrome caused by other forms of glomerular injury and inflammation, but the post-strep is really is a really good example of it. Excuse me. Nephrotic syndrome is different, and it is characterized by an increase in the permeability of the glomerular membrane. Okay. And as a result of that increase in permeability, you get albumin loss. Okay. So with nephrotic syndrome, something has acutely injured the glomerulus, and albumin leaks through, and you see this really significant proteinuria. Okay, this very, very significant proteinuria. So you get this marked increase in protein in the urine. You get this decrease in albumin in the blood, right, which often causes diffuse edema. Okay? And with this decrease in albumin, this is that kind of edema that we talked about before the last test, where it's this paradoxical fluid overload, right? Because the fluid leaks out of your blood vessels, it gets in your interstitial space, right? Which means that you have edema, including potentially ascites, okay? Whenever albumin levels go down, the risk for ascites goes up. And then what happens to your blood pressure? What's that? It plummets, right? It crashes. Your blood pressure goes down. That stimulates the renin-angiotensin system. Heart rate goes up. You start retaining fluid and water. So it's a paradoxical fluid overload, right? Because you have all of this fluid, it's sitting in your interstitial space, and you can't keep it in your blood vessels. Okay? So individuals with nephrotic syndrome will be highly edematous. They may even have some degree of ascites. They'll have low blood pressure, high heart rate, okay? High urine outflow, right? High urine outflow. Because as you can imagine, if you're leaking protein, right, water's going to follow that protein. Okay? So one of the biggest tasks for nephrotic syndrome is replacing this albumin. Okay? Replace the albumin. Now the liver if the liver is healthy, it is going to replace the albumin. It's just not going to be able to replace it at a rate that can keep up with the rate of loss. Okay? So replacing the albumin, or helping the body replace the albumin, and correcting the cause of the nephrotic syndrome is going to be critical. You actually see a bit of nephrotic syndrome or early nephrotic syndrome with women who are undergoing or experiencing preeclampsia. So women who are pregnant that have this disorder, preeclampsia, that's associated with actually an elevation of blood pressure, paradoxically, they will have damage to the glomerular membranes, and they will have protein in the urine, okay? And they will be edematous. Right? They'll gain a lot of water weight very, very quickly. Yeah. It's an osmotic diuresis. So if you think about the GFR, right? Remember we had the capillary blood pressure promoting GFR, hydrostatic pressure opposing it, and oncotic pressure opposing it. Now you're losing the protein. So now there's this oncotic pressure pulling, right? Increasing GFR. So with nephrotic syndrome, you actually have an increase in GFR because of this increase in permeability and the loss of albumin. So it's an osmotic diuresis, this pulling of fluid out. Okay. And this these flow charts are from your textbook, as you probably can imagine. So damage to the glomerular capillary membrane, loss of protein, okay? Excuse me. You'll also see this parallel or this subsequent hyperlipidemia as a result of the loss of albumin. The loss of albumin actually stimulates the liver to synthesize new albumin and for some reason also lipoproteins. But the low albumin decreases oncotic pressure. You get generalized edema, but low blood pressure, activation of the renin-angiotensin system, and sodium water retention, and more edema. Okay. Questions about nephrotic syndrome? Okay. So still on this topic of renal failure, acute kidney injury that can lead to acute renal failure, okay, tends to occur as a result of three basic mechanisms, and we kind of talked about this in patho. So a renal failure really means that the kidneys can't remove metabolic waste or perform their basic functions. Acute kidney injury is really a rapid loss of renal function due to some sort of injury. And the treatment is really aimed at replacing renal function temporarily, right? So temporary dialysis might be necessary. And minimizing complications, reducing any further injury, and preserving long-term renal function. The accepted criterion for acute kidney injury is a 50% or greater reduction, 50% or greater increase in serum creatinine. Okay? So if creatinine increases 50% or more, that is a really hallmark sign of acute kidney injury. You can also see oliguria, or decrease in renal output, or anuria, decrease in urinary output, or anuria, an extreme decrease in urinary output. Okay. Now, there's a couple of numbers that are good to remember in terms of urinary output. What you always want to see at a bare minimum is at least 30 mils an hour. Okay? You always want to see a urinary output of at least 30 mils an hour. Okay? Less than that, you've got oliguria. Okay? And it's not because of dehydration. It's not because of whatever. You have less than 30 mils per hour. It's because of decreased renal function. Okay. Less than 50 mils a day, your kidneys have basically stopped functioning at all. Okay. That's really the anuria. So if you can only remember two numbers, 30 mils an hour, 50 mils a day. All right? So causes of acute kidney injury or acute kidney failure, like we talked about in patho, pre-renal, intrarenal, post-obstructive, right? So pre-renal is really about renal blood flow. Okay? go back about an hour ago or a little bit more than an hour ago, GFR relies on an adequate glomerular capillary blood pressure. Okay? You don't have enough blood. You don't have enough blood getting sent to the kidneys to establish that blood pressure, then GFR declines. And that's what's going on with prerenal failure. So, hemorrhage, cardiac failure, right? Massive inappropriate vasodilation like shock. These are the things that are going to reduce renal blood flow to the point where GFR plummets. Okay? Prerenal failure does not mean that there's any damage yet to the kidneys. Okay? But if prerenal failure is not corrected, it will lead to ischemic injury, right? And once you start to get ischemic injury, now you're in intrarenal failure. So, intrarenal failure, prolonged renal ischemia, okay? Uncorrected prerenal failure. Nephrotoxicity. Okay? So, some sort of drug or contrast dye or heavy metal, right, or some solvent that you're exposed to, something gets in your system that is nephrotoxic, meaning it is particularly toxic to the tubular cells in your kidneys. Okay? That acute kidney injury, right, shuts down GFR and it shuts down renal function. Now, if you remember, usually when somebody goes into acute kidney failure as a result of nephrotoxicity, most commonly this is an iatrogenic cause, right? Meaning that it's an inadvertent cause, it's inadvertently caused by medical care. So, you have a 75-year-old patient, history of hypertension, diabetes. They're coming in for a CT scan with contrast. What factors in their health history are going to make you think, I've got to be particularly vigilant about pushing fluids on this patient? What are the things? Age, diabetes, hypertension, right? And then your lab results come in and you see that they've got slightly elevated creatinine, right? Which will be very typical of someone with that health history, okay? So let's say this is a hospitalized patient and day 2 of hospitalization, they go in for the CT scan in-house, right? And then they have labs done every day, and you notice their creatinine levels are going up, right? What's happening? Decreased GFR, most likely nephrotoxic acute kidney injury. So even though you pushed fluids like crazy as a good nurse, right, understanding this person's health history, they still were so vulnerable that the nephrotoxic agent still pushed them over the edge. Okay? Oftentimes the contrast dyes, there's pre-treatment to help reduce the nephrotoxicity, right? So this is where understanding So usually these drugs or contrast dyes that are nephrotoxic, they're not so nephrotoxic that someone who's with a healthy renal function, that person is not going to go into renal failure. It's always going to be someone who has some underlying vulnerability. Okay? Could be their age. It could be their history of diabetes, hypertension, whatever. It could be that they're already on 3 other nephrotoxic medications, right? They could be 30 years old and they're on 3 different nephrotoxic medications to treat something. And then they go in for a CT scan and they just didn't drink enough water. Okay? So all of these things increase the likelihood of that intrarenal failure through that mechanism. And then acute infectious processes, so acute pyelonephritis or acute glomerulonephritis can cause this intrarenal failure. Oh, and then post-obstructive or post-renal is caused by some sort of obstruction that it actually increases that Bowman's capsule hydrostatic pressure, right? That obstruction increases that hydrostatic pressure that overcomes whatever glomerular capillary pressure, okay, that is trying to promote filtration. So things like kidney stones obviously would have to be bilateral, right? Because as long as you've got one ureter, you're not gonna have renal failure. Tumors, BPH, strictures, blood clots, okay? Anything that obstructs the flow of urine out of the body. So, table from your book comparing clinical characteristics of acute kidney injury. So, with pre-renal failure, what you will see is things like blood urea nitrogen will go up and creatinine will go up, and the ratio will increase. So the BUN to creatinine ratio increases, which tells you that while BUN and creatinine go up, which one is going up more? The BUN. Okay? So that's something that you see that's pretty typical of pre-renal failure. Urinary output goes down, urine sodium goes down, sediment will be normal. Okay? So when you do a sediment analysis and you look at the urine under a microscope, you won't see any dead cells, you won't see any casts. Okay? Intrarenal, you have parenchymal injury. Again, BUN will go up. It's variable what will happen to creatinine. Urine output, creatinine will go up, excuse me. Urine output will go down, but varies. You will see casts in the urine, right? Or you will see abnormal cells in the urine because with intrarenal failure, you have damage going on to the parenchyma. So you're going to see shedding of debris. Okay? And then with post-obstructive, you will have a normal sediment rate and some of the other commonalities, the elevation in BUN and creatinine, and so forth. So just a couple of differences in terms of these characteristics or clinical variables with these different types of acute kidney injury. Okay, so preventing acute kidney injury. Adequate hydration. Okay? So patients at risk for dehydration